Welcome to the Neurology Live Mind Moments podcast. Tune in to hear leaders in neurology sound off on topics that impact your clinical practice. I'm your host, Marco Meglio, editor with Neurology Live. In this episode, we sat down with Dr. Alexa Dessy, a clinical assistant professor in movement disorders at Jefferson Health in Philadelphia, to discuss modern-day care strategies for patients with Parkinson's disease and other movement disorders. In the interview, Dessy covers the foundational role of detailed history taking, best practices in excluding incorrect diagnoses, and growing utility of genetic and imaging tools. She also talks about the challenges of managing non-motor symptoms, as well as the importance of clear and compassionate communication between patients and families as neurology becomes increasingly therapeutic. Let's dive in.
In movement disorders, the history and the physical remains really the most critical part of the evaluation. And the history is really focusing on the patient's experiences and the impact of their symptoms on their quality of life and their functioning, and getting input from their family members or caregivers, whoever's with them as well, kind of seeing what their external observations have been as well. And I think with regards to the examination, we're really observing the patient even before we're starting the formal parts of the exam. If we have the opportunity to watch them, as they're called up from the waiting area, or even just watching them as they're interacting with us during the history portion, what's their spontaneous movement look like? What's their speech sound like? Are giving us some of those initial clues before we sort of dive into the formal parts of the exam. And then in movement disorders, as opposed to some other parts of neurology where localization is really key, in movement disorders, we're really thinking about the phenomenology. So what does the movement disorder look like, and how can we sort of narrow down kind of what kind of movement disorder we're dealing with? So is it a hypokinetic movement disorder with a lack of movement, like Parkinson's and related disorders? We're dealing with a hyperkinetic movement disorder, like myoclonus or tics or tremors, dystonia, um, versus, one of the other diverse kind of movement disorders like ataxia or paroxysmal disorders, things like that we deal with. So the phenomenology is really, starting with the history, but then kind of looking into the exam of how can we narrow down what kind of movement disorder we're dealing with. I think from a diagnostic standpoint, the clinical evaluation is so key. But then sometimes imaging and other testing can be sort of helpful in confirming the diagnosis. So increasingly, I think we're relying on our genetic counselor to help with kind of diagnostic workup. Our neuromuscular colleagues at Jefferson are really helpful as well, because they're helping us with skin biopsies or EMGs or, other assessments of gait from a different perspective when that's needed. And then our other kind of interdisciplinary speech therapy, occupational therapy, and physical therapy are often really key in the management of our movement disorders. And so we're, a lot of the time that's a huge part of our treatment, as much as any medication or other recommendation that we're going to give.
Yeah, I think even over the last couple of years, it seems like there's more people that are kind of getting pushed into the room a little bit more, and for good reason, obviously. To have more experts and to have more specialists is obviously a little bit better now. Funding those specialists has obviously been a little bit of a challenge, to say the least. But I'm curious, Dr. Dessy, there isn't really one specific biomarker per se for specific movement disorders. I know alpha-synuclein has obviously been proposed for Parkinson's, but what are some of the more complex cases you face, and how do you kind of specifically go through some of the diagnostic process for some of the more tougher to deal with cases that you see?
I think a lot of the complexity of movement disorder stems from the variability in clinical presentation that any one diagnosis can have. And then there's the challenge of also distinguishing between overlapping conditions, and cases where there's mixed movement disorder phenomenology that we're seeing there. So again, I think it's always going back to the history and the physical exam, thinking about the phenomenology. And then in the diagnostic process, really, if there's still sort of a lack of clarity after doing those things, like diving back into them, like what's the developmental history, what's the exposure history, what's the family history, thorough review of systems of other body systems that can sometimes be involved in these more, systemic hereditary or genetic disorders that are maybe a little more rare and we don't see them as often. And then, the phenomenology is still really guiding the differential diagnosis, the workup, and then the management ultimately. And I think, utilizing these, while we don't have perfect biomarkers, we have some that are, within our toolbox. So thinking about an alpha-synuclein skin biopsy or a DAT scan or genetic panel or blood biomarkers, always thinking about what is an identifiable and potentially treatable movement disorder is always going to be top of mind as we're looking at things like chorea and ataxia and tremors, reviewing the patient's medication list. So really taking that holistic view of these patients. And then I think the other thing that can be really helpful is just using time. So a lot of the time in movement disorders, we're dealing with more chronic processes. And so if things aren't really clear on the first evaluation, kind of revisiting the exam and seeing the patient again, comparing the evolution and having two different time points to compare the exam is sometimes another way that we can get a little bit more diagnostic clarity. If things were really subtle and early in the beginning, we've let a few months pass, then maybe it becomes a little bit more obvious or clear. And sometimes also capturing the exam on a video, where we can then really zoom back into those subtle findings that we were seeing and also be able to review it with other movement disorders doctors. Can be another really helpful tool.
We're going to take a quick break from our conversation with Dr. Dessy to keep you up to date on the latest developments in neurology. Welcome to the Neurology News Minute. Here's what you may have missed since our last episode. First, during the Alzheimer's Association International Conference held July 27th through the 31st in Toronto, Canada, investigators presented new 4-year data into the efficacy and safety of lecanemab, an FDA-approved therapy for early-stage Alzheimer's. Notably, those with low tau identified in the extension's sub-study demonstrated the greatest benefit from the treatment. Days later, on August 1st, ICANX announced positive findings from its Phase 2 REPOSA trial testing IHL42X in patients with obstructive sleep apnea. Overall, the study met its primary endpoints in both dose groups, and based on these data, the company are discussing plans with the FDA on a registrational Phase 3 trial. And finally, on August 6th, the FDA approved an expanded indication for fremonezumab to include the preventive treatment of pediatric patients with episodic migraine aged 6 to 17 years old. With the approval, fremonezumab becomes the first anti-CGRP targeting treatment approved for both pediatric episodic migraine prevention and migraine prevention in adults. For more information about these stories, head to neurologylive.com, or you can check out the corresponding link in the show notes. And now, back to our conversation with Dr. Dessy.
Yeah, I mean, it's been awesome to hear the shift in conversations as to how we're treating patients with movement disorders and treating patients with Parkinson's. Specifically, obviously, we've got a few new approved therapeutics, which is good to offer to patients and at least have those conversations now. Now we're getting a little bit more specific with our diagnoses. So I'm also curious, Dr. Dessy, from your perspective, the conversation around specifically Parkinson's, and especially during the clinical trials, is always on time and off time, which for good reason is definitely a major concern for patients. But how do we best go about treating some of the secondary symptoms of movement disorders and Parkinson's specifically? Talk a little bit about how you kind of go about dealing with things like constipation, apathy, sleep issues, and fatigue. Some of those things that maybe don't get the recognition as on time and off time necessarily do.
Yeah, definitely. So sometimes these secondary symptoms, they can play as much of a role in someone's quality of life and function as their motor symptoms. So I really try to focus on them every single visit, kind of going through not only my motor review of systems, but really a full non-motor review of systems in Parkinson's. But I would say that for, as the general rule, our lifestyle factors and non-pharmacologic, management strategies are really always going to be my first line and go-to as we're trying to address these kinds of symptoms. So I think that also gives patients some agency and control over, things that otherwise sometimes feel like they're out of their control. But exercise is really key to many of these non-motor symptoms. So, in addition to just having the potential to slow down disease progression in Parkinson's, it helps with energy levels, it helps with sleep, it helps with mood, it can sometimes help with constipation or orthostatic hypotension. So that's something that we're really stressing at every visit, thinking about, asking the patient, what kinds of physical activity do you enjoy that you think you can do regularly, right? I don't want the patient to feel like they have to all of a sudden become like a cyclist or a marathoner if that's not, of interest at all. But if they like to go for walks with their dog, or they like to swim in the summer, whatever it is, that finding something that they actually enjoy that they can incorporate into their routine, and thinking about that like behavior change and how to make routine changes. I think that's really important with sleep too, is another one that we talk about a lot because it's really tied into fatigue and energy levels and mood. And so thinking about what's the underlying cause of the sleep issue too. So, are you waking up to use the restroom? Are you waking up because your mind is racing with, anxious thoughts and worries? Or are you having trouble falling asleep in the first place? Or is there snoring or dream enactment behavior, like REM sleep behavior disorder? So really trying to like dive into what is the underlying issue that's contributing to the sleep problem. Or, is there like an interpersonal family issue that's contributing to the mood or the lack of motivation to participate in certain activities, that we can maybe, help refer to a psychologist or a social worker to help provide additional support. So really thinking about those non-pharmacologic strategies and kind of lifestyle factors, behavioral change usually can help address many of the things that we're trying to deal with, especially orthostatic hypotension, thinking about hydration, that helps with our constipation as well. So we really, these conversations can sometimes take up more of the visit than the actual, dosing of the medication or the motor symptoms, but they're really crucial to kind of the overall quality of life for patients.
Yeah, well, I mean, as you said, these are things that sometimes patients even complain even more than they're often on time, and sometimes can be even a little bit more cumbersome than some of the things that necessarily take the front and center stage. So, a lot of great points for sure, Dr. Dessy. I appreciate you taking some time out of your day. I have one last quick question for you. As we've kind of shifted from a diagnostic specialty in neurology to a therapeutic one, now that we can actually have conversations about available therapies and even some new novel treatments coming into the fold, how important is the actual communication that you have between patients and families and yourselves? And just talk a little bit about the importance of how you're talking to patients, what you're talking about, and the things that you consider when discussing with patients. Just talk a little bit about the communication aspect, because this is something that I think flies a little bit under the radar, and we kind of sometimes forget as more therapeutics kind of come into the fold a little bit more.
Definitely. I think that's a huge part of kind of developing the therapeutic relationship with these patients who we're going to be following for a long time. Most of these diseases are things that progress over usually the order of years or decades. So really establishing that rapport in the first place and giving them the time to process any information that we're providing for them, giving them time to ask questions. But really thinking about a lot of the time the diagnosis that we're giving them can be really, impactful on both their lives, their families' lives. Thinking first, I think, about what was the patient's expectation going in and what was their base of knowledge. So what were they most worried about? What is their understanding of what is going on? If they've seen someone before they've seen me, like what were they told about their current condition, and what ideas they have about the diagnosis, because that sort of establishes that we all are getting on the same page, before we start going in and throwing more information into the mix. And, if the patient is most worried about Parkinson's, then we have a starting place. But if they have no idea what this is, then it sort of puts us in a different position. Or if they're worried about ALS or a brain tumor, some of those things are a lot easier for us to just sort of reassure and kind of shift gears towards what we are dealing with. And I think, communicating what we have seen on our examination is often really helpful too. So I'll point out the aspects of the phenomenology that I've seen on my exam, like when I observed bradykinesia or cochlear rigidity, what I saw when they were walking, so that they know, trying to give them as much transparency as possible, in terms of what I'm thinking while I'm evaluating them. Um, but then especially just giving them time to process things and giving them written information in addition to the verbal information I'm giving them, offering communication after the visit, either reaching me, on the portal or having the availability to call my office, because sometimes the questions are not going to come up in that immediate moment where they're sort of maybe a period of shock or, surprise. And then thinking about, giving them that space to say, okay, now that I've gone home, talked with family, these are the things that have come up, and making sure that they know that they can reach out to me before the next time I see them in a couple of months.
Thanks for listening to this episode of the Neurology Live Mind Moments podcast. To support the show, be sure to rate, review, and subscribe wherever you listen to podcasts. And as always, for more neurology news and expert-driven content, visit neurologylive.com.